sleep last night. I work as hard as I can. I bring home my money, take my money and give it to another man. I should have quit you, baby, such a long time ago.
Hi, this is Dr. Ed Park, and we're doing podcast 47 on prostate cancer today. The goals of today will be to learn what the prostate is and what factors influence prostate cancer incidence. We'll learn about treatment, diagnosis, and prognosis, and we'll learn how telomeres might relate to cancer generally and prostate cancer specifically in terms of mortality. Finally, we'll look into my cancer stem cell hypothesis and how my grand unified theory of aging and immune surveillance plays into that. At the end, we'll review my cases involving cancer and TA65, which, if you are taking or are considering a telomerase activator, will be of particular interest to you. Doctors are fond of saying or repeating that if you're 70, you have a 70% chance of cancer. This comes from cadaveric studies where they did autopsies on men who died of other causes and found that 70% of them had some form of prostate cancer. Now, if we look at the meta-analysis or the compilation of all the autopsy studies since 1948, an interesting thing emerges, which is that 5% of men under 30 had prostate cancer. When we look at the men over 79, that came to an average of 59%. So their conclusion from this study was that there is a substantial reservoir of incidental prostate cancer, which increases with age. The high risk of overdiagnosis limits the usefulness of prostate cancer screening. This from March of 2015, the International Journal of Cancer. What is the prostate? The prostate is the gland that makes the alkaline substance that prevents the acidity of the vagina from killing all the semen. In the middle, we have the bladder, and the urethra passes right through the prostate to exit the penis. Curving around on the right is the rectum, which is why the physician can reach in and feel that orange ball in the middle, the prostate gland. On the sides, there are seminal vesicles, and the seminal vesicles and the prostate together comprise 95% of the volume. So when you get a vasectomy, disconnecting that vas deferens from the sperm-producing testicles and epididymis, then you still have the same fluid and volume and everything else. Prostate cancer usually is diagnosed when a patient complains of having to pee frequently at night or frequent urination in general, hesitancy, which is the inability to get the stream started, and those all come from the mechanical obstruction that we would expect as the urethra passes directly through this abnormal prostate. You can also get painful ejaculation, blood in the semen and urine, and erectile dysfunction. The pain from this area usually refers to the low back, hips, or thighs. Interestingly, benign prostatic hypertrophy, which is the overgrowth of the prostate causing a lot of these symptoms that are not cancerous, tends to occur from the transitional zone. That's that yellow slice in the middle, and that is amenable to treatment with anti-testosterone treatments. And this is not where the cancer usually arises from. The cancer usually arises from the peripheral part of the prostate, which is biopsied, you can see in the lower right, transrectally. The physician will put a probe in the rectum right up against the prostate and shoot this core biopsy needle in there. Now, interestingly, as we'll discuss, the U.S. Preventive Services Task Force does not recommend PSA screening. This is really interesting because everyone does it, and even though their recommendation is weak, we have to talk about why everyone does that. When prostate cancer diagnosis is made, it's up to the pathologist to stage it and grade it. Well, specifically, the grading is done as shown on the right. When the glands are small, uniform, as they should be, then this is a well-differentiated cancer. The more separation there is between the glands, the less like a normal secretory cell type, the more aggressive the tumor is, down to the level of 4 and 5, which is not shown. these cells don't organize well. They're aberrant in their morphology and their architecture. So we use something called the Gleason grading, 1 to 5, 5 being really aberrant. And now they take a summation of the main type of cancer and then the secondary type. So if you have 3s in one area and another area which is 5s, then that could add up to 8 out of 10, and that's how it's staged. So up to like 4, let's say, I think maybe up to 6 is pretty well differentiated. In any event, what we're saying is that cells that don't play well together won't play well together. That means they're looking at how they look under the slide and just predicting, quite logically, that they won't behave and they'll be more aggressive. And indeed, that tends to be the case. There's also the TNM staging, tumor node metastasis, which is an attempt to standardize it, and the Whitmore-Jewett staging. But the point is, there's 99% 5-year survival when you take all patients, so to speak. So this is not like some other diseases where staging has a real impact upon treatment. Staging is largely grading based or under the microscope, and it's architectural, not cytological. In other words, it's not so much what the individual cells look like, but how they organize or fail to organize. Treatment is pretty simple. It's one slide here. Active surveillance is recommended for lower risk patients. That means that you just watch, you do exams, you maybe follow a PSA. And the principle here is that generally people will die before you can think to intervene. So my Latin is not great. I never studied it, but it would be, I guess, primum non nocere ante mortem. Primum non nocere is, of course, from the Hippocratic Oath, above all, do no harm. And ante mortem, I think, is before death. So the premise is quite morose, which is that they're going to die of something else. And indeed, later we'll visit a case of just that happening, or just that influencing the care of my friend's father. Treatment for prostate cancer is a radical prostatectomy, which is a very difficult procedure which almost always destroys the nerves around the erectile function. An alternative therapy is brachytherapy. They put radioactive needles in the area for a bit, and this is equally effective and a little less damaging in many cases, although it does make it harder to resect later because of the irradiated field. Transurethral resection of prostate is for benign disease. The idea of going in through the urethra and hollowing out like a pumpkin from the inside is thought to be a bad idea because of the risk of spread of metastasis into the bloodstream during surgery. Although there has been some interest in this in the age of quote-unquote active surveillance, some people say, well, rather than doing nothing but watching or doing everything and causing radiation or surgery, maybe we can resect out some of the tumor and help. But again, that is a controversial area. After treatment, chemical castration, an unfortunate term, which just means that you shut down the sex hormone production centrally through a pituitary hypothalamic blocker called Lupron, usually, is generally given. And we'll see an example of that later in Victor's case. Now, the 5-alpha reductase inhibitors, these prevent the conversion of testosterone to dihydrotestosterone in a more potent form, and they can cause breast enlargement, depression, and sexual dysfunction, both from erectile and libido standpoint. And they're not recommended for prostate cancer anyway, just for BPH or benign prostatic hypertrophy. The U.S. Preventive Services Task Force, which is charged with making these recommendations, has a pretty simple statement. Do not use PSA, prostate-specific antigen-based screening for prostate. And the reasons can be listed on this slide, but basically it comes down to the idea that these guys either are going to die of something else, or the morbidity is not worth it. In order to save one life, you'll be damaging so many other people. If we read the fine print here, it says the reduction in prostate mortality 10 to 14 years after PSA-based based screening is, at most, very small, even for men at the optimal age range of 55 to 69 years. Harms include pain, fever, bleeding, infection, urinary difficulties from biopsy, psychological harm of false positive tests, and overdiagnosis. Harms of treatment are erectile dysfunction, urinary incontinence, bowel dysfunction, small risk of premature death. So fairly unambiguous, although, again, everyone does it. A question is testosterone causal to prostate cancer? Does it cause it? Now, we used to say when we were in training that things like testosterone were anathema once you made the diagnosis, but now that, in the case of prostate, is being challenged by docs like Morgenthaler and others, and even the idea of estrogen in patients with uterine cancer, the old dogma that something good for the natural cell type will be good for the cancer is being challenged. Here's an interesting study from this year where people gave testosterone injections to combat lethal prostate tumors, and they found that there was a slight benefit, maybe because you had deprived them of the testosterone with the Lupron or the castration, and that changing it up, switching the conditions, would help to destroy these cells. But this is a pretty fringe idea. When we look at the evidence between telomeres and prostate cancer, an interesting study was published in 2013 in the journal Cancer Discovery by Meeker et al. And what they did was they looked at the prostate cancer with FlowFish, which is the technique that we use for measuring your life length, telomere lengths. And they found in 98 men had hypervariable, a lot of variability in their telomere lengths, and a general shortening. And in these people, they tended to die an average of 8.5 years later. 20 out of 98 of them passed away. Whereas when there was low variability in the telomere lengths, there was only one person that died out of the 98 in that arm, and he took 16 and a half years to do so of his disease. What does hypervariability look like? If we look at telomeres like birthday candles out of the box, they're all kind of similar and equal. If we look at them on the cake, maybe some of them are burning faster or slower. That would lead to hypervariability. And so if we look at equalizer, which is, let's say, pinned, everything is equal on the left, whereas if you're playing real music, there might be variability among those 92 ends of the telomeres. So we might not necessarily think that median length or the average length is representative. You could have a song with a whole lot of bass or a whole lot of treble, and that might just spell trouble for you. Forgive the wordplay. There is an interesting study of telomeres for prostate cancer, which was announced in 2013 at the Johns Hopkins School of Medicine. In it, Heafy et al. Looked at 596 prostatectomies. They put them in the fridge after looking at their telomere variability, and they hope to determine which of those tumors will be more virulent and harmful. I like this idea, but you have to realize that adding telomere grading, if we call it that, is only one inference. It's one level deeper than just the gross morphological Gleason staging. In other words, back in the day, we might say, well, if you have a tumor that's big and in your bones, that's bad. Okay, obviously that's tumor prognostication or staging. And then Gleason introduced this architectural way of guessing how the patient will do. And now if we look at the telomeres in the cell types, we say, well, if they're really bad, then the tumor will be really misbehaved, which makes sense. But I would argue that even though telomere grading will be helpful, what we really need are specific DNA assessments. There are many, many ways that all cell types, even cancer cell types, monitor themselves and kill themselves. So what would be most helpful for this and other cancers would be to have an assessment of which self-annihilation mechanisms are still intact so that we can best serve drugs or coax those cells into self-destruction. Because the truth of the matter is, even in a monster cell, a zombie, a Frankenstein, they are not rapidly changing necessarily, and they retain the traits of the original cell type. So Frankenstein he's got two arms, and he groans, and he's still able to kill himself. So I think the way to go in the future is not obsess over what's the prognosis, what's the way of predicting, but what can we do to kill these particular cells now that they're not killing themselves because they want to. So I liken it to this movie Minority Report, which is a story by Philip Dick, where they have three clairvoyants, and they try and guess who's going to commit crime. They're all predicting precognitively which people to arrest because they have a proclivity for crime. Well, that's kind of unfair. Maybe some people, if you were to do that kind of assessment on neighborhoods, like let's say some neighborhood in Detroit, or some neighborhood in a very poor, downtrodden area, you might say, well, these people are more likely to do crime. Well, how is that helpful? What we really want to do is integrate these people into a healthy lifestyle, rehabilitate them, or kill them. We don't want to obsess over this precognitive judging. It's not really about who's likely to be dangerous. Let's just go ahead and take care of the problem, or better yet, prevent it. One thing that everyone should know about is this Journal of the American Medical Association article in 2010, which was really a landmark. Most studies, vast majority, show that telomere shortening was associated with higher cancer incidence. Some showed that longer telomeres could be associated with cancer, and I have an explanation for that. But this took 787 participants, and it looked at their cancer incidence and their mortality over 10 years based on telomeres. What they found was that for every quartile, the shortest telomeres were in the biggest risk for getting cancer and for dying of it. So I would estimate 3,000 to 4,000 person years in my practice. So we would anticipate maybe 3 times 22 or 66 cases of cancer, and in the shortest, in the best group, we would anticipate the best case scenario. We anticipate 6 or 7 cancers, but as I will show you, I think we've only diagnosed 2 or 3, but we'll go over that. We're turning now to the more theoretical part of the talk, which is my cancer pyramid. I want to submit to you that our entire thinking about cancer is probably not very robust or sensical. There's an old Zen koan that says, if a tree falls in the woods and no one's there to see it, does it really fall? So the question is, do we really get cancer millions of times, billions of times? What is cancer? These are not just philosophical questions, they're important questions. I want you to consider the diagram to the right. This basically is my visual representation of what the state of the art is now. I believe that when we get cancer, it's clinically diagnosed, attention is poured on it, and if we're lucky, it's above ground, we can cut it out, we're done. It's more targeted, less destructive. Above that becomes radiation, which tends to be more destructive. And then above that is chemotherapy, which is basically dropping a neutron Agent Orange bomb from 10,000 feet and killing every good cell along with the bad, and that's more globally destructive. But what's hidden under the surface is the prevention pyramid. If it's really the case that we get cancer billions of times, all the time, as is suggested by that autopsy article, about 5% of men under 30 have some form of quote-unquote cancer, what we're really saying is that the base of the pyramid, the lion's share of what's under the water in terms of the iceberg, is telomere protection. Telomeres allow cells to age and die by virtue of the next layer of the pyramid, usually P53. When P53 detects that there are the wrong number of chromosomes, it will kill that cell, and that's a prime directive of every cell. Above that are the natural killers, which are the cops, the National Guard, the FBI. They're there to monitor your cells and they may be killing off quote-unquote cancer cells all the time in your life, which is why prostate cancer may be so indolent or non-virulent, because we're always getting it and we're always getting rid of it. So in terms of what we currently think of the big C word, cancer, we get this thing called the cancer martyr syndrome. Everyone, the family, the doctors, they rally around this poor person and the presumption is they're going to die. And so everything becomes real serious, it becomes real coalesced, the fear factor sets in, and of course what you resist persists. So we forget this theoretical idea that cancer is maybe happening all the time. Maybe we've beat it a million times. I mean, if you could say to somebody the first time they're diagnosed with clinical cancer, oh, and by the way, this test shows that you've gotten cancer 686,000 times in your life, so this is just one more shot at it, it might totally change the paradigm and the ability of the patient to heal themselves. And of course, once we hit them with the chemo and the radiation and the hopelessness, then we're helping those little critters to survive. We're creating environments for them to naturally select. And a lot of what we're doing in terms of cancer treatment may be counterproductive. It's funny, the reason I did this podcast was because I got an email last week from a patient, Tony, who's been taking, I think, at least, 6 TA65 a day for 3 years. He's a big believer. He loves it. So he sent me a text, and I thought he had prostate cancer. It was very upsetting to me because of countertransference, feelings that doctors get when their patients suffer. And so I decided, well, I'm going to tackle this head on because I've always had this concern about prostate cancer, and I wanted to make sure that I understood it enough. Of course, as a knee-jerk, I advised him to stop TA, get me his medical records, buy a book on alternative prostate cancer treatment, look into cannabis oil and reishi spore oil. These are all things that I would consider if it were me. But a few days ago, he told me he wasn't actually talking about himself. He's healthy. And so it must have been a language difficulty, which I'm grateful for. But the text is here on the right. It says, not me, I'm in perfect health. This is for my friend. And I texted, oh gosh, that's a relief. Okay, thanks. I'm sorry, but was this about a friend, a Labrador retriever? I'm confused. He had texted me saying, Dear Dr. Ed, I have a lab PSA of 390, which is very high, with now in the bone, ribs, and brain. Can we delay by any methods by a lot of recharge or TA65? So I guess it's enough time has passed that it's kind of funny. Not funny for his friend. I'm still trying to advise, but it turns out that this was not Tony. Another case which I thought I would present more fully, but I really won't, is Victor's case, which he's a brilliant guy. He's 88, taken TA65 for 2 years. And so just briefly, he was diagnosed around the age of 66 just by a PSA of 4.8, and they decided to Lupronize him. The biopsy waited until next year, and then at that time they did needle radiation therapy or brachytherapy when the PSA had risen to 7. At the age of 80, he started TA65. At 6 months, it rose to 16, and his doctor asked him to please stop. So he took bicalutamide, which is an androgen receptor blocker, and it dropped to 7. At that time, his metastatic workup to the bone was negative. So he stopped taking TA65 because of the concern, even though he felt great. And then after taking CBD, it also has dropped down to a more manageable number in the single digits. Why did I ask Tony to stop TA65? Why did I ask Victor to stop? Why did I agree to that? Well, it's a question of, first of all, watering the weeds. If TA is good for cells, it's good for all cells, which are stem-like, and cancer is a stem-like cell. But it's more a question of man bites dog versus dog bites man. A good example with vaccinations. If 20,000 people die of a vaccine, that's just the cost of doing business. But if one person dies from not vaccinating their child, from from not being vaccinated, then that makes news and it's political. So same thing with TA65. Even though we expect a baseline rate of cancer reporting to me to be dozens at this point, um, the fact that they are taking a telomerase activator, which so many aspersions have been cast upon, I would rather remove that from the equation, even though that may be not the best way to go. I'd like to share my cancer experience with TA65. I think it's somewhat illustrative. These are all the patients who I know out of probably 1,000 to 1,500 people who take TA65 and have come into contact. Of course, there might be underreporting, there may be pre-existing cases, but let's dive through these, shall we? It's not a big number. Starting at the top, there was a case of lymphoma. He was lost to follow-up. Another patient had a breast cancer, which was very suspicious because she allegedly had a negative mammogram within a year before. And then there is a patient who was diagnosed with ovarian cancer. I believe this was coincident with starting TA65. The other 4 cases, one was a colon cancer, which was diagnosed. It was treated completely surgically. Another melanoma, which was cured. One gentleman who's a surfer had 2 basal cells, and those were cured. And one lady had uterine cancer, which was cured. So I would say 2, maybe 3 cases of ongoing cancer, which were at least diagnosed during their TA course and who are still in treatment. In the middle section, we see probably what are pre-existing cases. One gentleman had long-standing lymph node enlargement in his neck and lungs, and he was diagnosed with sarcoid, which is not really a cancer per se. The second patient had advanced lung cancer, and last I heard he was doing well. A friend of mine's mother was diagnosed with stomach cancer very shortly after starting TA, maybe a month or 2, and she remitted after 3 years, or recurred, I should say, and now is getting another 6 rounds of chemo. Then there was a case of pre-existing lymphoma who did great, and another case who a gentleman said his father was taking the TA65 and then was diagnosed with prostate cancer. Details are scanty on that. At the bottom are the people who unfortunately have passed away. We have one gentleman from China who contacted me, and I never heard back, so presumably he died of brain cancer. Daryl Burge, who was the subject of our 10th podcast, hepatitis, very sad story, died just last month, or actually in end of May, after liver cancer. He had had Hep C for 20 years and was on pretty high dose TA65 for 4 years. After starting an experimental drug, which I think is like $160,000 in April, his AFP shot up to 10,000 range, and he was diagnosed with a huge amount of liver cancer, even though there was no detectable Hep C. And within a month of starting this experimental treatment, he had passed away post-operatively. Very sad. My friend, and TA65 patient, he told me his mom had cancer, and she passed away only 2 months after starting TA65 of brain cancer, but had arguably a pretty good quality of life and didn't want to go the chemo route. And then the subjects of the first podcast, Jackie Close and Layla Olson, they died. Jackie first of metastasis because I couldn't get her to find a doctor who would take out the primary, even though she had cleared her brain and spine of metastatic cancer. Doctors didn't want to do that because they thought she would be dead anyway. But it's kind of like leaving dandelions in there. Eventually, if you don't take care of the primary, you'll get more mets. And then Lila had a low-grade recurrence of ovarian cancer after a very good result of TA65, but her CA125 came back in the 30 to 50 range, I think, and instead of doing something more conservative, even a surgical cherry picking, she went with an experimental drug, and I think she was dead within 6 weeks. Finally, we'll talk about KK, who's my friend's dad, who died of prostate cancer. KK was diagnosed just a year after my own father passed of brain cancer, because of mental status changes. He was diagnosed with a lesion in the brain, which they thought might be due to his biopsy-proven prostate cancer. It turns out he had both prostate cancer and brain cancer. He received treatment for the brain cancer in terms of surgery and chemotherapy. Actually, not surgery, but radiation, I think, X-ray and chemo of his brain lesions. And despite that, it continued to grow over the next 4 years. The urologist declined to treat his prostate because they said the brain cancer would likely kill him first, even though arguably the prostate cancer at that point was not metastatic and perhaps curable. Again, there's a death expectancy. They call it life expectancy, but they really call it really mean to say is death expectancy. Interestingly, just a month or two after taking the TA65, whether it's related, we don't know. You can check that out in podcast 29. My friend's dad showed complete remission. His brain was half covered with tumor, and it was gone. And it would remain gone for the next 3 years. And during this time, his brain surgeon recommended that they take out the prostate. Again, like Jackie, they never took out the primary. Unfortunately, the urologist said, well, that's impossible. You're going to be dead of brain cancer, even though the brain surgeon said there was no more brain cancer. Eventually, they took the position that it wasn't ethically worth it for anyone to treat his prostate. Instead, they gave him experimental chemo, which was not known to be effective, and eventually he died very weak and succumbed to diffusely metastatic prostate cancer. Another kind of shadow that's been over the TA65 story has been from this class action lawsuit that was filed by an employee, a former executive at TA Sciences, arguably disgruntled, and he said that his prostate cancer was related to the fact that he was cajoled into taking TA65. This was resolved on December 11th of 2014 by a unanimous jury verdict saying that this former employee had been disgruntled and acted with malice to spread false and harmful information about the product and the company. And prior to that, the court had found that TA Sciences was not in fact using deceptive marketing acts and practices. So again, there is concern theoretically over prostate cancer, and the Nobel Prize winners and everyone else has come out publicly and said, I really wouldn't take a telomerase activator. My personal clinical experience has not suggested a higher incidence of cancer. In fact, people with existing cancers seem to do quite well in general up until the point at which they run up against death expectations and people eager to try out new therapies. That concludes today's talk on prostate cancer. I hope in the process we've learned a little bit about what the prostate is, how it is treated when it becomes cancerous, and raised a lot of interesting questions about whether this is really a disease and whether we're not constantly getting cancer of every type and constantly defeating it. So I would like to suggest that people adopt a little different attitude towards cancer. Instead of being a defining moment in your life, maybe just treat it as another thing that you've already dealt with. Because there's reason to believe that if we don't obsess over how we're going to die, we might actually have a better shot at beating whatever it is that is going on. Len asks, in your estimation, how long will it be before we have reliable telomere testing? We have reliable telomere testing in terms of the median length. We even have direct measurement and morphology of telomere ends. Again, I don't think that the telomere is the be-all and end-all. As crazy as that sounds from somebody who spends a lot of time thinking about telomeres, I think the telomeres are the, let's say, like the rust in your car. But what's interesting is not how your car rusts, but how you need to change your camshaft or, redo your pistons or fix your brakes. It's all, every cell type experiences telomere erosion and then stem cell mutation and then disease. So what we really need is measurement of not just the telomeres, because that's, again, what leads up to the problem. That's not the problem itself. Telomere erosion happens in two phases. There's a great study out of Northwestern showing that for 6 to 8 years, maybe before tumor diagnosis, there's a rapid shortening, which allows the mutation to occur. But then 2 to 3 years before clinical presentation, telomere lengths stabilize. And that's consistent with my hypothesis that once you get the firecrackers all the way to the fuse and they explode, then the cells go into crisis. And then it becomes a question of negotiating whether they're going to kill themselves, whether someone's going to do the job for them, how much are they going to play nice with their neighbors. And so they go into crisis, and then, even that is subclinical. So there's the carcinogenic event happens only when one of those ends gets short enough to explode and then get repaired. So that seems to be biphasic. There's shortening and then there's stabilization when they become transformed by crisis.
Squeeze me, baby, till the juice runs down my leg. Oh, do, squeeze me, baby, till the juice runs down my leg. I said the way you squeeze my lemon, I'm gonna fall